My name is Kilama Dennis. I'm a pre-intern doctor from Gulu University. Today we're going to talk about sickle cell disease and how we can prevent sickle cell disease and also their complication among the people living with sickle cell disease. To start with, sickle cell disease or sickle cell is an inheritable disease or condition which is characterized by abnormal shape of the red blood cell. A person can get this condition when two parents, say it may be carrier, that contribute one abnormal gene that would result into a child getting two abnormal genes of the red blood cell. This therefore means the person or the child become a sickler. When this child become a sickler, they will always get attack because the red blood cell, which normally is supposed to take 120 days, will now get distracted before making 120 days, mostly around 20 days or less. This sickle cell disease is a very prevalent condition, especially in the sub-Saharan Africa. Many of us in our region here where malaria is highly endemic. According to one study done in 2014, out of the Ugandan population then, according to the census of 34.9 million, 13% of the population were actually having sickle cell trait, and 0.73% were having the sickle cell disease. It is also projected that yearly we have about 25,000 to 30,000 children born with sickle cell disease, and of these, 80% do not actually make it to their 5th birthday. They die before that time. So how does sickle cell always behave, or how does it affect the body? That is the pathophysiology. What happens when someone has this abnormal red blood cell? What happens is that this blood will not flow as the normal red blood cell, which have a biconcave shape that can easily squeeze through small blood vessel. This sickle-shaped red blood cell will go and block the blood vessel, prevent the blood from moving away from a particular point or to the particular point. So if that happens, it is set kind of inflammation in those areas that is characterized by pain. Oxygen and nutrient is not able to reach the other side down where the position of blockage is. And then the red blood cell of such nature which have sickle cell shape can easily also be distracted. So when that happens, a child will normally present with the following features or signs and symptoms. However, when a child is not yet 6 months, the signs and symptoms of sickle cell disease may not present. So if they exceed 6 months of age, they will present with the sign and symptom of sickle cell disease. So before 6 months, there is mostly balance between the hemoglobin, which is for children, they call it fetal hemoglobin, and then the sickle hemoglobin. So the fetal hemoglobin prevent the sickle hemoglobin from what? Clogging or clamping together and blocking flow of blood. So if a child then exceed 6 months, that fetal hemoglobin become low and the sickle hemoglobin will now become more, and a child start presenting with what? Sign and symptom of sickle cell. As number one, there will be always recurrent pain. This child will always have severe pain, and the pain can be anywhere in the body, like along the long bone, the joints, or anywhere. There can be yellowing of the eyes, which come as a result of increased destruction of the red blood cell that release a chemical that cause yellowing of the eyes. There can be recurrent infection. This child will always fall sick with some infection. There can be swelling of the digits, like the fingers, the toes, those the extremities of the limbs. They can get swollen. A child may present with stroke, that is weakness on the other side, like weakness on maybe one side of the body. This stroke comes as a result of insufficient supply of oxygen to the part of the brain. Another thing could be failure to thrive. This child with sickle cell disease may not grow as child who is normal, because when this sickle cell disease, as I told you, blockage of flow of blood normally to parts of the body, mean nutrients and oxygen which are necessary for metabolism to ensure the body grow normally may not be well coordinated due to the blockage of the blood flow by the sickle cell red blood cell. So there can also, in male child, there can be priapism, that is sustained involuntary erection without any thought of maybe a woman or any of that kind. Then they can have ulcers in their extremities. These are wounds that are chronic and persistent. Then there can be frontal bossing. A child may have protrusion of the forehead. Remember, if a child presents with such kind of presentation, hurry to a nearby health facility so that diagnosis can be made. This diagnosis is made when you take a child. A proper history will be taken by the doctor, and then they will request for investigation. And this investigation, the most gold standard diagnostic test for sickle cell is SB electrophoresis. However, if your child has ever got blood transfusion within 3 months, this test is not done. There are other tests, but there's screening, so it's not so much important. The gold standard is SB electrophoresis, which can be done by a center with a good setup. For example, you can go here to Gulu Regional Referral Hospital, St. Mary's Hospital, that such tests can be done, and other recognized diagnostic center within the town. We also want you to know about the sickle cell crisis. These children always present with crisis, and these crises come especially when these children are predisposed to some of the risk factors. And the risk factor for this crisis are dehydration. When a child has dehydration, can easily get the sickle cell crisis. We have infection. If a child get any infection, whether malaria or bacteria, they can get the sickle cell crisis. Then doing extreme exercises or strenuous exercises or activity, this can predispose them to have the sickle cell crisis that we're going to look at them. Extremity of temperature, like extreme coldness or heat, these are some of the factors that may have these children get the sickle cell crisis or attack. Then psychological stress, when you subject this child to psychological stress in some families or environment where they live, that could be cause of the crisis or attack. Traumatic injury, some drugs also can be cause of the attack or sickle cell crisis. And sometimes the cause of this crisis are unknown. So the type of crisis which, if you predispose these children to those risk factors they present with, for example, the vaso-occlusive crisis. That is one we talk about, that the blood flow may be blocked by sickle cell, red blood cell here, and then blood cannot reach this side. So a child will present with pain in this area because of the swelling, inflammation that might have set in here, and then insufficiency of oxygen reaching this distal part where there has been occlusion. So it is one of the most common crises that are seen in sickle cell clinic. Then we have the acute chest syndrome, which is the second most crisis seen and is a major cause of death. A child which presents with acute chest syndrome will have difficulty in breathing, will have cough, will have fever, will have wheezing, that like noisy breathing that you hear them when they come to the clinic. They have those noisy breathing or musical like breathing sound. They can also have like fast heart rate, then nasal flaring. Those are signs of the acute chest syndrome, which are also the crisis that are seen. And I told you is the most cause of death among these children. Other crises are like hemolytic crisis. Here there's faster destruction of red blood cell by the spleen. We also have a plastic crisis, which is sudden reduction in red blood cells. Remember, this red blood cell I told you do not take longer as the normal red blood cell. The normal red blood cell 120 days for them to get distracted or to get old and destroyed for new one to come in. This one takes shorter, like 20 days to maybe 30 days. Then we have sequestration crisis. Here, the spleen get clogged and flooded and congested with the sickle red blood cell, and sometimes it become very painful. So if it become that painful, enlarged painful spleen, it is an emergency that will have to be what? Taken care of immediately. Yes, so the general principle of management to address those goals are proper hydration. You need to have these children have enough fluid, then adequate pain management, treatment of infection, oxygen therapy when needed, and blood transfusion also when needed. But the definitive curative treatment is bone marrow transplant, which here is still not accessible. As we can see our setup, especially in Uganda. The complication of sickle cell disease are retinopathy. Children who have sickle cell are prone to have visual problem like blindness. They can also have nephropathy, which is kidney disease or kidney failure. Chronic pain due to the ischemia. They can have heart disease or heart failure. Joint necrosis, especially at the joint, the head of the bone at the joint can undergo necrosis. Erectile dysfunction and also infertility, stroke, pulmonary hypertension, what we call sickle cell lung, when the blood, the sickle hemoglobin or red blood cell go and clog into the lung. Then failure to thrive, when these children are having problem with circulation of nutrients and oxygen in the body, they may not grow proportionate like their other children of the same age who are normal. Prevention of this complication can be pharmacological and non-pharmacological. The non-pharmacological having them take enough fluids, avoiding strenuous exercises, avoiding extreme of temperature like heat or cold, eating balanced diet. You need to have them eat balanced diet to reduce issue of malnutrition that may make them fail to thrive well. Avoid physical stress or psychological stress that sometimes subject them to the attack. Then education on the early future of this condition. The pharmacological prevention includes some of the routine care that are given to them, like folic acid that are given in the sickle cell clinic, prophylactic antibiotics, malaria prophylactic drugs like Fanchida, which commonly known by people here in Uganda, but it's a combination of sulfadoxime and pyrimethamine. Immunization, ensure these children get immunized fully. Then another way which is still being enrolled in the country is the use of hydroxyurea. This is one that actually will reduce frequency of admission. because the hydroxyurea increase the concentration of the fetal hemoglobin more than that of the sickle hemoglobin, therefore reducing the occurrence of the crisis. But the challenge is many of the patients cannot yet afford this hydroxyurea. So if it will become available through the government or other partners' initiative to support the sickler, we shall have improved quality of life. The last part is now prevention of sickle cell. How do we prevent sickle cell? If we prevent complication, yes, we are caring for those who already have, but preventing sickle cell is solely a responsibility of us when we understand that sickle cell is an inheritable disease. So if we want to prevent, we need to take care while choosing partners. And we need to take genetical counseling and screening prior to marriage or conception. So when you are about to get married, it's good as you screen for other disease, also screen for sickle cell. If they find that you are a carrier, then your partner, if your partner is normal, it's okay, you can marry. That means you are not going to have children with sickle cell. But if they find you are a carrier, your partner is what? Is a carrier, you will be given counseling on the risk of having to live or produce a child who is a sickler and the problem associated with having to look after them. Then you choose otherwise whether you want to continue to get married or conceive and produce a child with sickle cell or not. The same if you find that you're a sickler and your partner is a carrier. There's probability of producing a what? A sickler. So it is still upon you when you get this information to decide whether to go ahead conceiving or marrying and then producing children with sickle cell, or ending the issue of marriage and then finding another way. It's an ethical dilemma, and also when you look at the surrounding religious, cultural beliefs about marriage, sometimes it make it hard to implement this, but it's upon us, the generation, to think what quality of population of generation we want to have. If we want to have a sickle cell free generation, then we need to take genetical counseling and screening prior to marriage and conception as a very important way of preventing sickle cell disease, such that we have maybe two people who are carrier marrying normal people, sickler marrying normal people, and then we shall reduce numbers of children being born with sickle cell in our community. Thanks.